Hi everyone, and welcome to another webinar co-organized by A&T Neuroeducation. My name is Farnoosh, I'm the head of education, and I'll be gladly hosting today's session on state-dependent transcranial brain stimulation, a plaidoyer for personalized, adaptive, and scalable solution. Our presenter today is Professor Alexander T. Sack, who is one of the world's most renowned experts in non-invasive brain stimulation, fundamental and applied cognitive science, and clinical brain stimulation research. He is currently appointed as chair and full professor of brain stimulation and applied cognitive neuroscience at the Faculty of Psychology and Neuroscience, Maastricht University. Also co-director of the Interfaculty Center for Integrative Neuroscience and scientific director for the TMS clinic at the Maastricht University Medical Center. He is also principal investigator of the research section Brain Stimulation and Cognition at the Maastricht Brain Imaging Center. This session will be followed by a short relevant demo of a navigated TMS session presented by Dr. Giulio Di Cosmo, who is an application specialist in A&T Neuro. Afterwards, we'll have a question and answer session in which Dr. Oksana Lielka will also join us from the product management team of Wiser2 to address any questions you might have from the technology side. For those of you who are first-timers in this platform, you can always type in your questions in the chat box so that they're discussed at the end of the session. Also, in the course of the presentation, we will raise some poll questions designed by Alex. Please make sure to actively participate in the poll questions to make the session as interactive as possible. So without further ado, let's get to the presentation. Alex, many thanks again for accepting our invitation and being with us here today. We're all ears to hear all about your interesting research on state-dependent brain stimulation. Thank you.
Yes, thank you very much. I'm very happy to be here. Thank you very much for having me, for inviting me, for organizing this. I hope you can all hear me well and see my slide. If not, let me know. Thank you also for the nice introduction. And I would like to start with putting a bit of stress on the organizers by starting the very first slide with the first poll. So turning to you, the audience here, and I have a question to you. And that is, what is your main interest, if you have any interest in non-invasive brain stimulation? A, is it that you are interested to use it as a basic research tool, cognitive neuroscience? Are you interested in the clinical potential? Are you already treating patients, or you would like to treat patients with brain stimulation? Both of those, or neither of those, you are here more by accident or forced by your supervisor. Or I can also select.
Okay, as you were speaking, actually more than 85% of the participants already voted.
Okay.
Yeah, now 90%. I close the poll and share the results. 42% selected a basic research tool. Another 42%, both above, 13% to treat patients, and only 4% neither. I'm here by accident. Well, that's interesting still.
It's very interesting. So welcome to these 4% that are here by accident. Please stay with us. It could be interesting after all. And a very interesting result to see that we have a mixed audience, people that are interested in the potential of brain stimulation as a research tool, in brain research, and also as a clinical tool. So I'll try in my talk to address both aspects in these 30 minutes or so that I have. Thank you for this, for participating in this poll. So let's get started. So I would like to talk a little bit about transcranial brain stimulation or non-invasive brain stimulation. Transcranial by definition mean that it's non-invasive because it's brain stimulation that you apply transcranially through the intact skull. And there are different technologies available that are transcranial and therefore non-invasive. And I will focus on two technologies here. The one is TMS, here on the right. TMS stands for transcranial magnetic stimulation, and there the idea is that you apply magnetic pulses, time-varying magnetic pulses, through electromagnetic coil that is placed again on the outside of the head, on the scalp of your subject or patient. And because you apply strong time-varying magnetic pulses via electromagnetic induction, you can induce an electric field in the brain. And because the neurons communicate with electric signals, you can actually stimulate the brain. You can actually induce neural activity transcranially with TMS. And another technique is TES, transcranial electric stimulation, or sometimes also called low output or low intensity transcranial electric stimulation. And here you place a couple of electrodes, at least 2 electrodes, on the outside of the scalp of your subject or patient, and a very low intensity current, a couple of milliampere flows from the anode to the cathode, and thereby you can also stimulate the underlying neural tissue. The neurophysiological mechanisms are slightly different compared to TMS, but I don't have the time to go into the details. It also doesn't matter that much. Important is that both of these technologies have been used in basic research in healthy volunteers to stimulate, to inhibit, to change neural activity as an independent variable, and then do experiments on human behavior, human cognition, to understand the relationship between brain activity and human behavior in an experimental setting. And both of them have also been successfully used as clinical tools to treat different neuropsychiatric disorders, because depending on the protocol that you use, you can not only have immediate effects on the brain, but you can also induce longer-lasting neuroplastic changes that are outlasting the stimulation itself. And of course, those are interesting effects and protocols for clinical purposes, where you want to treat a disorder that is associated with a certain pathological hypo or hyperactivity in the brain. And you can counteract this using a respective protocol that will increase or decrease activity in those networks affected by the disorder, and change neuroplastic mechanisms on the synaptic level that are outlasting the stimulation itself, so they have lasting effects. So this is in principle, in a nutshell, what transcranial brain stimulation can do. And as I already said, in a way, if you think about it as a research tool, it does the exact opposite from non-invasive neuroimaging. So non-invasive neuroimaging allows us to non-invasively measure task-related brain activity changes, for example, in an fMRI scanner. So we have people put in an fMRI scanner and let them do a working memory task, for example, and then we measure which areas in the brain are activated during the execution of this task. While TMS is doing the exact opposite, there we are stimulating or inhibiting, depending on the protocol we use, certain brain areas in our subjects. And then we measure the behavioral effects of this experimentally induced activity change on performance in this task. So therefore, it makes a lot of sense, to me at least, to combine both of them if you want to really study the relationship between the brain and our cognitive abilities or human behavior. If you want to complete the entire circle, it would be meaningful to combine imaging with TMS. And this is also what many people do for many decades now in this kind of research. You see here an example of a former PhD student of mine in an fMRI scanner, just for demonstration purposes. She's instructed to tap her right index finger, and the fMRI scanner can very easily identify which area in her brain is activated during the execution of this simple motor task. Not surprisingly, we find here an activation hotspot in her left hemisphere, because it's her right index finger, in the hand nub of her motor cortex. This area is active. That was the first part of the experiment. Now the person is out of the fMRI scanner in the TMS lab, and I'm using, back then, that's 25 years ago, I'm standing behind this PhD student and using a self-built neuronavigation system to position the TMS coil on her head exactly above that activity that I measured in her brain in the previous fMRI session. So I use a software that co-registered her real head with a reconstructed head from the MR images, and I'm using a motion tracking system to, in real time, track the movement of her head and the coil, and the software all puts that in the same reference frame, so I can in real time navigate the TMS coil to the exact area in her brain that I want to stimulate, which is the area that shows this activity blob when she's moving her right index finger. You see me here standing behind her. When I move the coil on her head, in real time, the reconstruction of the coil in the software, in this navigation software, moves with me, and I'm trying to get the magnetic pulse directly above that activation area in her left hemisphere. And whenever you hear a click sound, I'm giving a TMS pulse. I'm activating this area in her brain. And whenever I do this, I make her finger now move beyond her control, because I turned the entire experimental situation around. I'm not measuring her brain activity anymore, but I'm inducing it, and I have an observable effect on her motor performance, in this case, finger tapping. And of course, this in the motor system seems maybe a bit boring, because you could have found that spot also by just hunting, by trial and error, by stimulating different areas across the motor cortex until you find the finger twitch, and many people do that, and that's fine. But of course, if you're outside the motor system and you don't have a direct observable effect of your TMS, then this fMRI-guided neuronavigation, as we call it, is very, very vital. And just to demonstrate this to you, very old research from our lab from 2007, in the context of a cognitive task, in this case, a number processing task, we first did the fMRI in a couple of subjects to identify the area in their brain, in their right parietal cortex in this case, that is most active when those people perform a number processing task. And you see here on the right, these 5 different clusters in different colors, blue, red, turquoise, yellow, green. Those are not different areas. Those are all the same area in terms of induced by the same task. These are just different people. These are different participants. This is the individual variability in which exact area within this parietal cortex, the intraparietal sulcus, is recruited by those subjects when they perform this number processing task. So every brain is different, every person is different, and also the peak activity cluster is different across these subjects. And now, in order to really specifically target the exact activity in a given participant, you would need to have fMRI-guided neuronavigation. And this is what we've done. And then we see whether we can actually change their performance in this number processing task. And we compared this approach of targeting the TMS coil based on their individual fMRI data using neuronavigation. We compared this approach, as we call it here, fMRI, to other ways to position the TMS coil, namely based on the individual anatomy. So we're ignoring the functional information from the fMRI scan, where we just look at individual differences in brain anatomy, and then we place the coil always on the same anatomical structure. That's MRI. And then we had an approach where we use group data from the literature, and we back transformed that into native space of that subject. And we used, let's say, the group average to position the TMS coil. And lastly, we we ignored all of the fMRI, MRI data altogether, and we went for a scalp-based approach, which is just placing the TMS coil over an EEG electrode position, in this case P4, because P4 is supposed to overlay the right parietal cortex. And as you can really see, and that's the take-home message from this study, is that these different targeted approaches really had different effects on behavior, with the most robust and the strongest and most significant behavioral effect of our TMS manipulation only observable when we position the TMS coil using individual fMRI-guided neuronavigation. So in the research context, where you have a clear target based on fMRI data, it makes a big difference for your findings if you position the TMS coil based on a preceding fMRI scan to localize the exact individual target in these subjects. But as a next step, of course, even though it's informed by a previous fMRI scan, the actual behavioral effect that we can get, and I showed you an example of a number processing task, but there are thousands of papers out there using TMS to change performance across a wide range of behaviors and cognitive tasks. And you have these significant behavioral changes. But the big question, of course, is when you have TMS and you apply it somewhere, even if it's neuronavigated, and you measure a behavioral change, you still, of course, don't know what you exactly induced in the brain in terms of neural activity changes. You're always assuming that by placing the coil somewhere on the scalp and people then are better or worse in performing a task, you're assuming that you probably have changed something in the brain, but you don't see it if you just have a TMS lab with a coil there and you measure behavioral performance. The only way to really fill this gap of, okay, I can change behavior cognition, and in the clinical context, I can even change clinical symptoms, great. But what is really going on in the brain when I stimulate with TMS such that I have these behavioral and clinical effects? This you can actually only address empirically if you go one step further and you apply TMS in an fMRI scanner during the scanning. So a simultaneous combination of TMS and fMRI, where a subject or patient is in an fMRI scanner doing a task, and while performing the task, you measure brain activity, and then you apply TMS in the scanner, and you have behavioral effects in the scanner, and at the same time, you continue scanning the brain, so you see which exact neural activity changes are underlying these behavioral effects that you see with TMS. And this is technically a more complicated setup, but still for a long time already, this is technically possible. And there are MR-compatible TMS systems available. And a couple of groups have done a lot of research on this, including our own group. You see here a publication again from a long time ago, 2007, where we applied TMS over the parietal cortex in an fMRI scanner, measuring the whole brain response to TMS on a neural level, and at the same time having a behavioral task that those cognitive tasks that these subjects had to perform. And we also measured their behavioral performance in this task and brought all of these parameters together. And there were three important take-home messages from our studies and also from many other studies that followed. What we learned from doing TMS during fMRI, we learned three important messages. The first one is that when you apply TMS somewhere on the cortex, because the cortex is more or less the only part of the brain that we can directly reach with TMS, you apply it, for example, over the parietal cortex, here the SPL, superior parietal lobe, then you will always have an effect that is not restricted to the area that you target, but you will always have indirect effect, remote effects. So you always stimulate an entire network. That's in any case with every kind of TMS stimulation the case. Wherever you target the TMS coil, you will have a network effect that is comprised of cortical and even subcortical areas that react to your stimulation. The second take-home message is that those network effects that we find, they are not always the same. Even if you do it a couple of times in the same subject, it's not always the same network that you activate, but which area you activate, which network, depends on the cognitive state of your subject. And this is something we showed already in 2007. So if I put somebody in a scanner and I place the TMS coil over the parietal cortex and I apply the same physical parameters, I might get a certain network when this person is at rest, and I get a complete and entirely different network when this person is engaged in a specific cognitive task, let's say a memory task. And again, I get a different network effect of my TMS when the person is engaged in a different cognitive task that is, for example, not engaging the area that I'm stimulating. So the network effects, the local and remote effects, the entire network is completely dependent on the cognitive state in which the subject is in when you stimulate. And that's a very, very important message, because it has a lot of implications for individual variability that we see, reliability problems that we see in research, and also the clinical implications are immense, and I will come to that towards the end of my talk. The last and third take-home message I forgot is that we also showed in research that I have no time to go into, is that also the indirect effects of TMS. So the effects that I don't get by stimulating an area directly, but the stimulation effects I have on areas that are just functionally connected to my stimulation target. So they are far away from my coil, but they are connected to the area that I stimulated, and therefore they're also manipulated. That those remote effects of TMS, they could actually be the reason why I see a behavioral effect. So that makes the whole causality wish that people had that introduced TMS into cognitive neuroscience, that finally we have a tool that can prove causality, makes it a bit more tricky, because it might as well be that you place the coil somewhere over area A, but without knowing it, you're actually also manipulating activity in area B that's connected to A, and this change in area B is the reason why you see a behavioral effect. And without knowing this and showing this in images, you are still in the dark about which exact area is functionally relevant for what. So this is all old stuff, and now I want to change gear a little bit because it's puzzling, right? So if you have network effects of TMS, and they are different in quality depending on which cognitive state your subject is in. So I have a network when somebody's doing a working memory task, and I have another network being activated by the exact same TMS protocol to the exact same region if somebody's doing an attention task. What is the state dependence of TMS? What is the neurophysiological mechanism behind this? And there now comes a neurophysiological principle of brain network communication that we know already for many years is important in how the brain works, but we tend to ignore it in fMRI research, and we also tend to ignore it in TMS research, where we mainly think about networks in terms of a spatial layout, and we think about TMS targeting an area and then targeting a network. So all this terminology already shows you that we are completely obsessed with that spatial component of how functions are coded in the brain. But we know already from animal research, from electrophysiological research, that a very important parameter in how networks communicate, how brain areas communicate, is actually in the temporal domain, in the rhythmic activity within these networks. So areas in the brain are never just active or not. They are fluctuating in their neural activity patterns. You see here, for example, the spiking of different neurons as dots over time. You see this rhythmic on and off waves of spiking activity. And if you plot this as local field potentials, you can actually see those waves, this rhythm in 1 second, and you can count those cycles, and then you can say that something oscillates in 10 hertz or in 5 hertz or in 20 hertz. This is neural oscillatory activity, and these neural oscillations are actually used by the brain to not only code for mental representation, but mainly also for communication. So that within a network, if a signal wants to spread from one area to another area, like we've now seen in TMS, these network effects means that my TMS signal is spreading from the cognitive cortical target to the other remote regions and to subcortical regions. This is all done. This communication, the spreading, is all done using neural oscillatory activities, and we have ignored this completely so far. So it is important to bring these three things together. So the network and the oscillation, and we need to integrate this all into one research paradigm. And to do that, we would need to combine not only TMS and fMRI, doing TMS in the fMRI scanner, but we also need to add EEG, because EEG is the method that has the temporal resolution to pick up on this oscillatory activity changes. And therefore, here in Maastricht, we worked for more than 10 years to build a setup where we can combine TMS, EEG, and fMRI all simultaneously to integrate, let's say, the connectome, which is about the spatial layout and connectivity, and the dynome, which is temporal dynamics of brain activity that form those networks. And here I want to show you data from our research where we apply TMS again in an fMRI scanner during different cognitive brain states. We again found that TMS has a complete network response, so not just one region, but a complete network is responding. And now we added EEG to not necessarily measure the EEG response to TMS. No, we actually added EEG as an index of the oscillatory brain state at the moment of our TMS application. And this makes sense if you follow me to the next part of this slide. We know that oscillatory parameters play a big role in signal propagation and communication within the network. And then it could be that if the spontaneous fluctuation of, for example, the alpha oscillations, they are spontaneously fluctuating from moment to moment, even within a cognitive state. You could measure your alpha oscillation at any moment in time, and you would see that depending on small changes in your cognitive state, they would fluctuate spontaneously from moment to moment. And this is happening all in the background. So we could now do an experiment where we test what happens if my TMS pulse that I apply to the network happens to be applied at a moment when, for example, the intrinsic spontaneous power, so the amplitude of the alpha oscillation is high. Maybe then, because alpha is used to inhibit information flow, so if alpha is high, maybe then the signal that I send into the brain is not spread out, is not propagated. Then maybe your TMS effect will be very limited, only to the area that you target, and it's not spreading around the network because the power of alpha is high at that moment and is thereby inhibiting the propagation of your TMS pulse. And at the same time, following the same logic, if you apply in the same subject to the same area with the same intensity, the same TMS pulse, but now it happens to be applied at a moment where the spontaneous alpha power in this area is low, maybe then, because now the gate is open, so to say, your TMS pulse is actually spreading through the entire network because it's now ready to be propagated from the cortical target to all the other connected regions. This is a hypothesis. This is something that you could speculate. And this is something that we then tested in humans using the setup where we integrate the oscillatory and the network effects of TMS. And this is exactly what we found. So you see here 3 different lines, red, green, and blue. And this is the fMRI bold response. So the response as measured by the fMRI scanner locally, where we place the TMS coil. And you see 3 different strengths of neural activity induced by TMS. But it's not that it's 3 different intensities of TMS or 3 different subjects. No, this is all the same subject, the same intensity, the same area. The only difference is that at the moment when we apply the TMS pulse, the spontaneous intrinsic alpha power was either low or high. And you can see if the alpha power was low, then we had a very strong response to TMS. And if the alpha power was high, we had a very weak response to TMS. Again, the EEG was just indexing the oscillatory brain state as the perfect and most sensitive way to assess cognitive state. And we see that the state dependence is immediately translated into what TMS actually induces in terms of a neural effect as assessed by fMRI. But more importantly even, because we all depend on these network effects, the question whether our TMS signal, our TMS energy that we introduce here on the cortical level to that area, whether this actually is sent through the cortical-subcortical network to deeper lying structures like the thalamus in this case. It can be propagated to the thalamus, but the question whether this is really the case, again, depended on the power of the cortical alpha oscillation. Following the same logic, if the alpha oscillation was low, so the gate was open, then the TMS pulse that we applied was propagated through the network all the way to the thalamus. But if the gate was closed because alpha power was high, then there was no signal propagation from the cortical target to the subcortical remote region. So a very interesting finding published here in 2020 and having huge clinical implications, I believe, because of course many clinical things that we do with TMS, like depression treatment, is also depending on network effects that we want to induce. And we hope that our cortical stimulation stimulates a depression network, but this only works or relies on our signal being propagated to deeper lying structures. And we here show that this is not the case if you don't consider the rhythmic activity, the oscillatory brain state, which is optimal for this communication within this network. I skipped this for interest of time. This is another study that we did to confirm using another technology that you can be at the right spot to have effects also on networks that are interesting you. But if you don't have the right communication frequency, you will not the network effects that you want to have. And this is an example from placing a high definition TACS, transcranial alternating current stimulation device, on the parietal cortex, hoping to modulate the functional connectivity to the hippocampus. So a deep lying structure that's normally out of the reach of TACS, but you can reach it. You can reach it by functional connectivity to a parietal cortical target site. And this is what we've done. But what you can see here, we stimulate the parietal cortex with TACS inside an fMRI scanner to assess whether we actually can change the functional connectivity to the hippocampus at different cognitive states and using very different frequencies of our TACS. So these are oscillation frequencies that we are externally using via the non-invasive brain stimulation tool. And you can see that testing sham, testing 5 Hertz, so theta, gamma, beta, alpha, so we went through all different or prominent frequency bands. We found that only in the theta frequency band, so theta TACS, in a state-dependent way, was capable to modulating the connectivity from the parietal cortex, where we place the electrode, to the hippocampus. So it is not only relevant to know where you need to stimulate, but it's also very relevant to have the right rhythmic and individualized oscillatory state informed protocol if you want to have robust network effects of your brain stimulation. And this brings me to my next poll question, which is just, I made my point here, but I would like to see how you feel about it. Which technologies can best be combined with non-invasive brain stimulation? Do you think the biggest strength is using fMRI for personalizing the targeting, or EEG for personalizing the protocols, the frequency band, like I showed you? Or you think both are equally needed, or you actually think that none are really needed because there's so many interesting stuff already done without these sophisticated combinations? Do we have results already, or? Are the results in, or?
Yes, I just closed the poll, and here are the results. The majority, 76%, voted for both are equally needed. 16% voted for EEG, 6% for fMRI, and 2% none are needed.
It's very good. You are a very kind audience. So I try to make my point that both are equally needed, and you agree with me, which is nice. Thank you very much. But we can discuss this, of course, also later on. I have to hurry a little bit because of the time, but I want to, because I saw some of you also interested in clinical applications. So this is all fundamental research, and there's a lot we will do with this in the next couple of years. But it also has already implications for clinical applications of TMS. And I take the example of depression because it's the most well-known and most investigated clinical example. We know a lot of things already. We know it's successful in treating depression. Is actually a recognized treatment in many countries, including the Netherlands. It's reimbursed by health insurance and so forth. But what we do in TMS is that we are targeting a cortical region, the dorsolateral prefrontal cortex, mainly because it's just a region that we can target with TMS because it's on the outside of the cortex. But the actually antidepressive effects are not because we're modulating the dorsolateral prefrontal cortex activity. This is not the depression region. It is only because this region is a window, a door into a wider ranging network, including many subcortical regions that are connected to that stimulation site. And therefore, by having this network effect, we also have the antidepressive effects. And depending on whom you're talking to, there are different, let's say, remote regions that seem more or less relevant. One region that's very en vogue at the moment that is talked about a lot is the subgenuine anterior cingulate cortex. So this particular functional connectivity between the dorsolateral prefrontal cortex that we target directly with TMS and its connectivity to the SGACC is at the moment considered to be a very relevant connectivity that you need to modulate successfully with TMS if you want to have clinical effects. Now, a lot of people then still in clinical practice just place the coil somewhere and give the standard 10 hertz or 1 hertz or theta burst protocol that is one size fits all. And it works in let's say, every second patient, you have very good results. But it also means that in every second patient, we don't have that great results. And the big question is why that is. And one road many of my colleagues and myself are going down now is to try to more personalize this depression treatment. And this is a grant we got in the Netherlands where we tried two things. The first one is very trivial and not something extremely innovative. And this is not to just to place the TMS coil at a standard one-size-fits-all place. No, we want to turn it around. We start with an fMRI. We do a seed-based functional connectivity analysis, and we identify the area on the cortex that we want to target that has the best connectivity to our actual target. That could be the SGACC, but it could be other. Could be amygdala, could be hippocampus. Whatever you are interested in, you use that as a seed, and you let the data tell you which cortical area in this particular patient is most correlated or anti-correlated to your target, and then you use neural navigation to place your coil on that personalized target. That's the spatial key. The SAINT protocol, for example, is also using this component for those who are familiar with this. But my point is that this is great towards personalization, but it's not enough, because what I showed you before tells us actually that even if you're on the perfect spot that is anti-correlated or correlated to your actual target deeper in the brain, by just randomly giving any kind of rhythmic activity, you are running the risk of not having the TMS pulse being robustly sent and propagated to your actual target, because you are ignoring the communication frequency with that network. So what we want to do with our setup, the EEG-TMS-fMRI setup, in a fundamental study, is to find out which oscillatory band within the depression network is the relevant one that we need to sync to in order to have the most robust and strongest depression network effect. Could be power, it could be also the phase of the oscillatory band, it could be alpha, it could be theta. This is something that we explore in the next couple of years. And then we have the temporal key that we need to add to the spatial key in order to have the really individualized depression treatment. And if that all sounds very, very, let's say, practically infeasible, because not every patient can in the end do fMRI TMS EEG experiments, is very expensive and just not practical. Important to realize is that this fMRI study, you only need to do one time for the localization. So it's just one scan. And once we identified the frequency within the network that we need to sync onto with TMS, we also don't need that three-way combination anymore. We actually can use a closed-loop EEG trigger TMS, or even use TACS to entrain this particular rhythm and apply TMS pulse at a particular phase or power level that we are experimentally entraining by coupling it to a TACS device. So this is just a one-time thing, and the rest could be a very feasible, practical solution for our patients to personalize this treatment. And the last couple of slides, I know I'm running a little bit out of time, it's just to make the point that although the depression treatment is already, let's say, standard care, Also here in Maastricht, in our hospital, it's reimbursed by public health insurance, so everybody is entitled to get the costs reimbursed. There is a lot of innovation still needed for us to understand and to further improve the therapy, and to find out why some patients benefit so well and others not so well from this treatment. And I think this personalization is one way to go. Another thing that I want to point out is that although it's great that we have these clinics popping up all over the world and people go to these specialist clinics and get the TMS, I think if we want to really make a change in the mental health care system, we need to offer something that goes beyond this acute treatments of 4, 5, 6 weeks of daily visits to a clinic. We need to take our patients also beyond that acute treatment phase and offer them something for more sustainable effect. And this is where I asked the last question of my presentation: where is the digital revolution actually in non-invasive brain stimulation? If you think about what happened to all our technologies from the 80s until today, a lot of development you see in things becoming smaller, more powerful, wireless, smart, connected, cloud-based. When it comes to TMS, this is a TMS device from the 80s, the very first one. And you compare it to TMS nowadays, it hasn't really become much smaller or variable or wireless. So I think there's a lot to be gained, and that's my plaidoyer at the end then, to increase accessibility and the scalability of this very powerful treatment for various disorders, not only depression, but also many other neuropsychiatric disorders. So my vision for the future is that we still need the in-clinic TMS and all this technical complicated setup that I showed you to calibrate and personalize the patient's treatment protocol in the clinic. But if we want to have sustained effects, we need a real-world application. This can only be done remotely supervised neuromodulation at home, maybe even self-learning systems. So you eventually integrate the neuromodulation technology with sensing and monitoring technology to have a closed loop that is self-learning, and also at one point even predictive and preventive rather than acutely treating neuromodulation. And there are a couple of technical developments by a couple of companies that try to provide these wireless home use devices for non-invasive brain stimulation. And I think this is very exciting development that I'm also actively participating in. And this brings me to my very last question to you. This home use neuromodulation is, of course, very new, and it also comes with a maybe controversial discussion. So my question is: do you think that home use neuromodulation has a future? Yes, to increase accessibility and scalability would be A. B, no. I think non-invasive brain stimulation should only happen in a clinic. And C is non-invasive brain stimulation at home is mainly interesting for maintenance.
The poll is ongoing and already 60% voted. So let's wait for a few more seconds. Perfect. 80% voted. I just closed the poll, and here are the results. The majority voted for the first one, 65% yes, to increase accessibility and scalability. 10% said no, should only happen in clinic, and 25% the last one. It's mainly interesting for maintenance.
Yeah, interesting that that's rather a minority that feels that NITs should only happen in a clinic. So I think there's an interesting basis for discussion. But with this, I would like to end the official part of my presentation. I of course want to thank my great team in Maastricht. Many of the results and data I showed is not my own work, but work by my PhDs and postdocs, assistant professors. So most of the credit has to go to them. But I have one final question, because it's a personal interest of ours, because we are also providing these clinical trainings for clinical practitioners that want to use TMS for their psychiatric or neurological patients. And we see that there is a growing mismatch between let's say, this dynamically developing field in a science bubble where we have all these insights and things are changing from month to month, and we publish this in publications. And the private practitioner, the clinicians in the field that don't have that access always to those publications. This is actually at least my feeling I get from training actual practitioners, clinicians that want to offer TMS service to their patients. So my question is, do you all have access to relevant articles? Yes, I can freely access all publications. B, in principle, yes, but I have no time to regularly scan the literature. C, only limited access to publications. And D, that's a mistake here on my slide, D, I have no open access to publication.
So more than 75% voted already. I just closed the poll and share the results. Unfortunately, the majority belongs to the third option. The third one, only limited access to publications, and 9% have no open access to publications, whereas 33% can freely access all publications and 20% just don't find the time.
Yeah, very interesting. You see that there's quite a proportion of people that have either limited or even no access to these publications. I find this personally a big problem because we are all funded by government. I'm working for a public university. This is all funded by tax money. We do all this research. It has clinical implications. We publish this in journals, but these journals are not free. You have to subscribe to them. We have to pay a lot of money to make them open access. That's not always possible. But the actual people that are treating patients now, and TMS and TCS is the prime example of this. It has moved from the lab into the clinic. So there are private practices that use this technology to treat their patients. They should be informed directly about something that is relevant for them to know. Things have changed so much in how we position the TMS coil, what protocols we use, things that we learn every year needs to be communicated quickly. And I know, and this poll confirms it, that especially people outside academia that are practitioners don't have this access to the scientific development. This is therefore something that I just want to point out here. We have started a month ago only on our LinkedIn site, which is the International Clinical TMS Certification course, where we have this connection to the clinical practitioners that are not working at a university, but they're psychiatrists or neurologists or psychotherapists with a private practice offering TMS to their patients. They come to our courses, and that's where we have noticed this gap between scientific research on the one hand and the clinical practice. And we want to bridge this gap, and therefore we have started on a LinkedIn page where we provide free and open access to relevant scientific publication from the international brain stimulation literature and inform there about new scientific developments. So there we try to scan the literature for you. We'll summarize the most relevant facts, and we give link to the open to the full article for you to read yourself. So if that's something that interests you, just follow this LinkedIn page, and we'll do our best. This is a team of colleagues and clinicians that have access to most of these articles. We'll do our best to keep the link as close as possible between academic, scientific research on the one hand, and the clinical application, the clinical practice on the other hand. With this, I would like to really thank all of you, and I apologize for being much longer than I had time. Thank you.